So today we're talking about the Baker cyst. So this is the 73 years old lady. She complained knee pain and present with mass at the posterior region of the knee. So that's the trans illumination test. You can see that there's a big Baker cyst in the back. So Dr. Lim, what is your approach to the Baker cyst? Lawrence, how is your approach for the Baker cyst?
Sir, I don't have personal experience, but I saw I saw some of your patients from the outpatient,
Mm-hmm.
and you approach the baker's arthroscopically.
Yeah.
Before I saw some did it
Uh-huh.
yeah, through the posterior incision from the back.
Okay. That is the open procedure, right? And do you know what is the indication for surgery? Do we need to do surgery in every Baker cyst?
If it's enlarging and it's symptomatic, sir,
Mm-hmm. Yeah.
it depends on the patient's preference. A lot of them.
Okay. So the patient would have pain in the back of the joint, and you can try the aspiration first. Okay. If you're after aspiration, if the patient feel much better and the pain is gone, okay, you can prove that this pain is coming from the Baker cyst. Because some Baker cysts have no symptoms, you don't need to touch. Okay, so many osteoarthritic patients, they have the Baker cyst, but they have no problem. You need to define, is that the symptomatic or asymptomatic Baker cyst. Okay, I always try to aspirate the cyst first. First, I prove that this is the true Baker cyst. Okay, um, and I want to know that after the aspiration, if the patient pain is gone, that proof if you do the arthroscopic surgery for this patient, the symptom will be better. You get it? Okay. So try
Yes, sir.
aspiration first. So I will try 2 or 3 times. Okay. Because some patients they're satisfied, just satisfied with the aspiration. Okay. But if not, um, you do arthroscopic Baker cyst removal. But before doing that, you need to prove, is there any intraarticular pathology? But yeah, what is the intraarticular pathology that associated with the Baker cyst?
I think the meniscus also a degenerative change on the degenerative tear of meniscus is associated pathology with papillomatosis. Yes.
Mm-hmm. So there's two causes that common association with the Baker cyst. Number one is the meniscus. Okay. Number two is cartilage problem. Any cartilage problem, or sometimes if the patient have the synovitis, persistent synovitis like rheumatoid, okay, arthritis, sometimes there's produce a lot of fluid, and that may the cause of the Baker cyst. So looking for the cause of the synovitis, because most of the cases they have cartilage problem, and most of the and the number one cartilage problem is the osteoarthritis, right? Okay, and don't forget to look for the synovial disease like rheumatoid, synovial chondromatosis, PVNS, something like that, that produce a lot of fluid. Okay, and also the meniscus. Okay, good. So that's the X-ray of these patients. Just some arthritic change, but she did not complain the joint line pain. Her main complaint is the pain in the back of the joint. Okay. Okay, so that's MRI. You can see that the big Baker cyst, and also the patient have some meniscus problem on the medial side. Okay, and that the Baker cyst. Sometimes you may have some loose body inside the Baker cyst. So that's the MRI after the aspiration. You see the cyst is getting smaller. Gong, Do you know what is the opening of the vagal cyst? The valve, the opening of the vagal cyst is getting out between which structure? Kong.
The Baker seat have the one-way valve with the posterior capsules leakage
Between
on
it's
the
it's like a tail, you see? It's leaking from this small valve between these two structure. What's the what is that? What is that? Medial gastrocnemius and the semimembranosus. Okay, so that is the medial side. This is the semimembranosus. Okay, and that is the gastrocnemius medial head. Okay, so it's coming between the gastrocnemius and medial head, medial head of gastrocnemius and the semimembranosus. Okay, and you see that the cyst is here. If you come from here, you cannot see the cyst. You should come from lateral, you see? That is the PCL. If you want to get into the cyst, you should come this direction. That is patella tendon, right? My scope should come from here, you see? The direction, okay? From here to the notch, right? And medial to the PCL. Then you open this cyst, then you can get into the cyst, okay? So it's like diagonal. And this way itself, because the vascular structure is here. If you come from lateral to medial, you have no chance to injure the vascular. Okay. So that's why I propose the technique of the Baker cyst surgery. Yeah. Let's see. So you need this supine position. Break the table. Make sure that you can approach to the back freely. The knee need to bend 90 degrees. Why? Lawrence again. Dr. Lim, how about your
to
microphone?
let the vessel fall back.
Yeah, let the vessel fall back. When you bend the 90 degree, you have more space. Whenever you extend the knee, the posterior space will be obliterated. Understand? You need to bend 90 degrees so you have more space. So put the sandbag underneath the tunicate. Make sure that you can bend 90. That's important. Okay. Same like we do PCL reconstruction, you need 90 degree. Okay, the vessel will fall back. After that, we make the arthroscope. Your scope have to be very close to the center. Before doing that, I aspirate the cyst again. Okay, we aspirate the cyst. Okay, if the patient have really high pressure, sometimes when you just put the needle in, there will be fluid will auto reflux, or there's a positive pressure push the syringe. Then we inject the dye into the cyst. That is the sterile methylene blue. Okay, that is the sterile methylene blue into the cyst. Okay, you see that? We do this before we apply the tourniquet. Then you go between the PCL and the medial femoral condyle. Okay, your scope portal should be close to the center. You see that? That is the PCL and the medial femoral condyle. Show you. So this is the right knee, right? Right knee. This is the medial compartment. Right? Right knee. So you should go into this compartment between the medial femoral condyle and the PCL. Okay? Like that. Okay? So this is medial femoral condyle. That left hand side is the PCL. So try to find this and go between. Okay? The way to go to the back, you put your scope to the notch, right? And then extend the knee until you see the PCL. Then you pat your scope into, okay? and turn the post to be like this, nearly 5 to 6 o'clock. Okay, and then you can go straight. Understand? Okay, otherwise your view will not like this. Another way to do that is you can use the switching stick, put your scope on the medial side and put the switching stick from anterolateral to the notch, to the medial compartment. Okay, so you can do two ways. If the joint is not too tight, you can put the scope directly into the posteromedial compartment like this. Okay, I show you here. Put the scope into the posteromedial compartment, right? And then you put the needle. Okay, and if the patient is not too thick, you can turn off the light to see the trans illumination. Okay, and put the needle in. So this needle will be just above the joint. Okay, and about 1 centimeter behind the prostrom, from the posterior condyle of the femur. Okay, like that. And then use the knife, okay, to open the posteromedial. Okay, then identify the valve of the cyst. Okay, you always see the valve of the cyst. Some patient the valve is very wide, and some patient the valve is very close. I mean the fluid cannot leaking out, but some patient the valve is not so tight. You can see the fluid leaking from the valve. Okay, like this. Here you can see that. Okay, this patient, you see the dye. So you slowly taking out the cyst wall, okay, and then you can see the dye. Then you follow the dye into the cyst, okay, like that. See that? That's a valve. Okay. Now you can see the valve, right? And then you follow your scope into this valve, okay? And the cyst wall will be stained by methylene blue, right? You can see very well where is the cyst. Okay, like that. Yeah, you see? Then you follow the methylene blue, okay, into the cyst wall, okay, by using your scope. Then you get into the cyst. You see, it's like big cyst with the lining synovium, okay. Then now your direction is like this. You see, your direction is coming from lateral to medial. As I told you from the MRI, you can see that you have no chance to injure the nerve, right? So I will put like figure 4, okay, and pass my scope into the cyst and directly go out to the posteromedial, okay. And when it's go like that, you can see the vein. The only thing that you can damage is the vein, not the artery. There's no artery in this area, just the vein, okay. If you see the vein, you avoid injury the vein because you can see it very well using the knife and then open the cyst. See that here? There's nothing. Then you make the penetrate to like this. Put the knife like that. It's safe, right? And then you put your scope from front to back. Okay, like that. Can see well? I repeat again. Okay. Careful, your knife should be just tap incisions and then you dilate, okay? Front to back. And then follow with the shaver. But very careful at this step. You should not move your knee because otherwise your cannula can be broken, right? Then you can see that the cyst wall was stained by the methylene blue, okay. So that's very useful because when you shave, you can know that after you remove this blue, that means your cyst wall is gone, okay. So using the shaver and then slowly cut that. You see, after you cut the cyst wall, you can see the fat tissue. Do not go beyond fat tissue. You stop When you see fat tissue, stop. Okay, like that. And when your cyst wall is already cut, it can be easily sucked into your shaver. So don't move too much. Okay, and the vital structures is close to the center. Okay, so careful when you're moving very close to the center. Okay, like that. Yeah, swelling, take it off. Okay, like that. See? And then slowly cut the cyst wall. And very careful about the not going out because you can damage the small vessel. You see that? That is the tendon, right? The middle-head cardstock nemeus. So after you remove the cyst, it will be like this. You can see the fat tissue. That means you complete, right? You remove the cyst wall about more than 50 is fine. Okay. So the technique is that you need to remove the valve and also remove the cyst wall and get rid of intra-articular pathology like synovitis, loose body, meniscus. Okay. So any question so far?
If the patient have some other associated lesion, which step do you prefer do, like the meniscus or cyst first?
So we do the cyst first before we doing, because if the knee getting swollen, it's not easy to work, you know. I manage the cyst first, okay, before it getting swollen. So after you finish your cyst, now you coming to the anterior compartment, it will be easier, okay. Gong, any questions? Lim? Man,
Yes, I have a question. Is there have the difference between resect the valve only between when compared to the resect the valve with the cyst wall?
Okay, so there's some study about that. Someone just proposed to just remove the cyst valve. Okay, I used to do that also, but now I change. I remove the valve and also I open the valve to make it in and out easy, not one-way valve, right? And also I compare with my result using the valve dissection together with the cyst wall removal. My result of the cyst wall removal is better. It's better. Okay. So I'm not sure about that is the personal experience. We didn't have the comparative study yet. Okay.
With the good result, it mean that have no recurrence.
Recurrence, yes, no recurrence.
Thank you, sir.
Man, no.
No, sir.
Okay, Lim.
Lawrence. I have a question. I don't get it when we are in posterior middle corner. And what is the point? I mean, where do we go to the valve? Because what we are seeing is only a capsule reflection, right? From the posterior middle corner. So where do we start to shave first?
That like pan over waist like this. Okay. So you remove this part, take this out. Okay. Then you can see the cyst. Okay. Understand?
But where do we start first? From where we start?
We start identify the valve first. Posteromedial. Okay, I can show you. Okay, and after that you come and see that here. I show you. Here we coming from the medial side, right? So this one is cardstock or semi-mem. This one.
Semi-mem.
What is this one?
This is semi-mem.
This one?
Yes.
This one semi-mem. What is that one?
Medial head of gastroc.
Yeah, that is cardstock. Okay. gas duct will be more central because your RF is coming from medial, right? Okay, right hand side is medial, left side of the monitor is the lateral or central, right? This is central. So identify this, and you need to make this clean and wide. Okay, so that's important to see this. You need to see that this is gas duct, this is semi-mem. Okay, this triangle and all the cyst wall was already removed. Okay, the benefit of using the inside out, like I show you, is that your hand can move freely because you will not obstruct by the condyle. Okay, because it's free, because you make it inside out, so it's can free, you can move, and you can switch your cannula also if you cannot see very well, because using 30-degree scope sometimes cannot see very well. You can switch your camera to be 70 degree. 70 you can see better, right? Because the 30 degrees sometimes you have some bright spot. So 20 degree you can see very well. Okay, switch your camera until you feel that you remove the maximum cyst wall. Okay, good. So after that, then I cleaning the cartilage problem, the unstable cartilage, and also the meniscus of these patients. We do some cartilage at the tibia, also the femur, and then we do some viscosupplement injection for her. Okay, so like that. Actually, her knee is not too bad. She has some condyle damage. You see that the meniscus also have the radial tear, so I fix her radial tear also.
What implant is this, Dr.
That
Bancha?
is Johnson, I think. Johnson. กล้อง you save this the video because we have a talk about the two span.
span ครับ
Okay, so that's it. Good breathing. Okay, after surgery. Okay, thank you, Arisna, for editing the video.
Sir, I have a question.
Yes.
Because previously when you showed the valve, it's usually quite large, and this patient, you can see that there's a tissue covering the valve and it's very good. So when in your experience, the normal valve is usually a bit, that area is a big hole, right?
Yeah, right.
For the normal patients, and
So
for those with Baker's.
Some patients you cannot see the valve very well, like these patients. When we get in, you see that here. I need to remove some part of the capsule here when we get in. Yeah. Okay. So this patient, the valve is not easy to identify, right?
Correct.
Okay, when we get in here, see? So I try to find the valve, okay, and after you remove the posteromedial capsule, you can see that it's connecting like this, okay?
So meaning the valve is big enough, we can see the valve at that area.
Yes, right.
Okay.
So you can, I think we have so many Baker cysts. You can find another patient and send to me. I can share you, okay?
I censored the groups, the fellow groups. I sent another page.
Another patients, right?
Professor, I have a question.
Yes.
It is possible that I cannot find the valve without the dye injection before arthroscopy.
What do you mean?
I afraid if I have no dye to injection into the cyst and I go arthroscopic surgery without dye injection, so I afraid about I cannot find the valve.
You can find every time. But if you're experienced, you can find the cyst without dye, okay? But if you're the beginner, I think better to inject the dye in because it can guide you. Because you are maybe you are not so familiar with anatomy in this area. So better if you have the dye, you can follow the dye. Okay? It's easier.
Thank you,
Otherwise,
sir.
you can get lost easy. Okay? So this is another bigger cyst, right? So this one you see that the cartilage is so nice. See the second case. This is look very nice. See, look so healthy the cartilage. So same way we do aspiration. It's a very big cyst. You see, very big. So we aspirate and then we inject into the cyst. Okay, it's very young. I think these patients very young. And some Baker cysts have no valve connections, like Baker cysts in children, right? Okay, some Baker cysts they have the Baker cysts without valve. So these patients, we go to the postural medial, right? Here you see this is a valve. You see, this is a pan over waist. So if you take this out, drag this down, you can see the cyst. Okay, you see that it's like pan over waist. Okay, so now we coming from here and then we remove the valve. Okay, then you can see the dye now. Okay, I remove the capsule because the infrared capsule here that cover, you need to take this out. Okay, to make the valve wider, and you can see the gastroc and semi-mem very clear. Okay, now you can see the dye leaking out. See, okay, the tricky point is that when you see this, you need to push. Sometimes you cannot get into the cyst. You can use your instrument to push the gastroc numerus to the central, because this gastroc will block your entrance. Okay, so I use this instrument. Sometimes I use a suture retriever to push the gastroc numerus to the central part, and then you can pass into the cyst. Okay, like this. You see that it's leaking. So now I cleaning, remove. You see, I need to push. You see, I need to push this to open the cyst. You see that? Sometimes I use the shaver. Sometimes I use the suture retriever to push the gastroc numerus to the central. And then you see this dye, right? You follow the dye into the cyst. See that? I need to clean a little bit. Okay? Then after that, you follow the cyst follow the dye into the cyst. Okay, this is a classic same way, right? We put the switching stick. You see the marking? You see my marking? What is that? Dr. Lim, what is that? In the back. Don't know.
No.
Lawrence, what is that?
Not sure. The This is medial, sir, right? The veins, the
the veins.
saphenous.
The veins, because the only structure that we can damage is the vein. So before you deflate, before you using the tourniquet, okay, you mark the vein with your pen first, so you can know where is the vein. Understand? So you be safe when you make a inside out, you not damage the vein.
Yes, sir.
Okay, and then make a stab incisions. Same way, small stab incisions. Okay, and passing. Okay, like that. And then you follow into the cyst like that. Use your shaver. Very careful when you use a shaver, just suck it in. Okay, you see, slowly cleaning the cyst wall. Okay, so the cyst wall can easily cut after you um, cut it, so it will be like this. You see, you can easily suck your cyst wall into the shaver and remove it like that. But careful at the central part. So I remove the cyst wall as much as possible. Some patients have the septation. There's a wall between the inside the cyst. You need to break the septum also. Okay, you see. So don't move too much. You just suck it in. It's safer. Okay, like that. You see that the cyst wall of this patient is so big, so big. Really big. That is a liner. Okay, and always deflate the tourniquet. I need to make sure that I didn't damage any vascular, to say any active bleeding. Stop the bleeding. Okay, before you stop. Okay, so then this is after surgery. So after surgery, sometimes the patient may have the fluid collection. Okay, don't worry. You ask the patient to sleep in prone positions. Sleep in prone. Put some pressure, cold compression at the back of the joint, because it's now there's no valve, right? The fluid can leak into the back of the joint, and sometimes you may have the loculations in the back of the joint. So advise the patient to sleep in prone, massage, and also put cold compression. So finally the cyst will disappear. Okay. So the result is pretty good. In my experience, I have only one patient that come back with recurrent. That patient have infection and the cyst recurrent because of the infection. Okay. So clear. Any questions?
Do you have some tips regarding how can you prevent over shaving?
Over shaving, like I told you, if you're getting close to the central part, okay, if you're getting close to the central part, if you're not sure, very very slow, and you can leave that part. Okay, don't need to take it out.
Okay, thank you,
Yeah,
sir.
your aim is to open the one-way valve mechanism and cyst wall. Take out the cyst wall as much as you can. Okay.
So I see that before you open the valve, you use electrocautery, but for the cyst wall and valve removal, you just only use the shaver, right?
Right. You need to use a shaver because the cautery cannot remove the cyst wall. See, I use the shaver, but you see, the way I use the shaver, I do it very careful. You see, I don't move that much. I just suck it in. Okay, like that. Okay, slowly, like this. You see? Just suck it in.
Thank you very much.
Okay.
Sir, do you prefer a big shaver or the small?
The
This
routine
size?
shaver, 4mm shaver, routinely, same. Okay. Very careful. Go slowly, like that. Okay. And always change to 70-degree scope. Switch the cannula, okay, to see better, because you can have some blind spot using 30. 30 is good if you see the view is in front of you. Okay, the 70-degree scope can see of wider view. Okay. Okay, good.
What if my center don't have the 70 degrees scope? Can I still
Yeah, you can
do it?
use that. You switch your camera uh, to the posterior compartment. Put your shaver into the posterior medial compartment. Switch, switch it.
Okay.
You have another view that can see better.
Okay.
Okay. Okay. So that 1 week after the surgery, the patient recover very fast.